A very good evening to all. So, I'm Dr. Azeem. I have done my MD Paediatrics from PGM at Chandigarh. So, happy to be associated with SPEED. So, this is a novel initiative taken by SPEED Institute in order to discuss the topics in the form of concepts, so that these concepts are imbibed in you guys and you get a holistic approach to an entire topic. So, what we do is we discuss with one topic at a time. The questions or the topics which are going to be discussed as an MCQs in this class would be highly yielding, and there would be these would be the questions which have been asked in the recent exams. So it would be a good way to discuss that topic in entirety, and that's how this session is going to be useful for all of you guys. So we go with the first question. We have one question today. We'll be discussing the topics in and around related to this question, this topic. Of the following, the most accurate statement about folic acid supplementation for prevention of neural tube defects is that prevention is. The options are associated with the reduction of anencephaly rather than meningomyelocele. Dose of folic acid for secondary prevention of neural tube defects is 0.4 milligram daily. Effective folic acid supplementation is effective only during the stage of neuronal proliferation. Risk of recurrence is about 10% if previous two siblings are associated with neural tube defects. So there are 4 options given, and 4 options talk about different aspects of neural tube defects and the utility of folic acid in them. So first of all, the first option tries to understand your knowledge regarding the neural tube defects, whether anencephaly and meningomyelocele both are considered as a neural tube defects, or they are 2 different sorts of neurological abnormalities. That is the first option. The second option is, what is the dose of folic acid? So if there's something called as secondary prevention, there should be something also called as primary prevention. So the examiner is trying to find out what is the dose of folic acid when you use it for primary prevention of neural tube defects, and what is the dose of folic acid for secondary prevention of neural tube defects. The third option is whether it is effective only during the stage of neuronal proliferation or the other stages of neural development also. So that is what is being asked about, third thing. And the fourth option is the risk of recurrence is 10% if the risk of recurrence is 10% if the mother or the family has 2 siblings which are previously associated with neural tube defects. So I'm not going into the answer of this question upfront because we'll be discussing after the explanation of the concept and the topic. So this question basically tries to understand your knowledge about what is the development of central nervous system, how thorough you are with the central nervous system, what are the predisposition of what are the predisposing factors which are going to result in central nervous system abnormalities, and what can you do to prevent the neural tube defect. So these are the things which you will have to remember. So the first thing you have to understand is the entire central nervous system is originating from surface ectoderm. The notochord and the intraembryonic mesoderm plays a very important role in the development of central nervous system. It is in the first and second week of development where this notochordal plate will invaginate the surface ectoderm, and and the neural fluid will also invaginate, resulting in neural groove, which goes on occurring in third and fourth week of development. Over a period of time, the central notochord will occupy the central region of the developing central nervous system to form the central spinal canal. Now this, when you see it in a longitudinal section, makes basically your spine visible in a situation where it is completely open from the back. So the neural groove which is there is extending from the cranial to the caudal end. So the tissue starts getting closed from anterior to the posterior, that is from the rostral to the caudal area, resulting in 2 openings left, that is the rostral or anterior neuropore and the caudal or posterior neuropore. So over a period of time, these 2 pores also close and result in development of central nervous system. Any defect during this growth of central nervous system will result in abnormalities of central nervous system. So if you have to remember the events which are occurring in the development of central nervous system and correlate with the gestational age of the baby, you need to understand that the neural plate formation occurs at 18 days of gestation. The neural groove forms at day 20 of gestation. Neural tube forms at day 22 of intrauterine life, whereas the anterior neuropore closure occurs in the day 24. It is the posterior neuropore which is going to close at the last that is day 26, and bulk of the neural tube defects or the neural central nervous system abnormalities are going to happen in and around these days. So this is about this development of central nervous system. Are there any problems associated with this going to result in disorders of central nervous system? Definitely yes. So we have neural tube defects, we have disorders of neuronal migration, and we have other miscellaneous malformations, which we'll be discussing in subsequent slides. So then the next question is, what about folic acid and what about neural tube defects? How are these two linked? If you see, the problems of neural tube defects will occur because of the failure of the neural tube to close spontaneously, and that is happening between the 3rd week to 4th week of intrauterine life. So because this is the time where bulk of the central nervous system development is going to happen. And it has been found that the neural tube defects are the most common CNS anomalies overall. Now we look into the predisposing factors. If you list the predisposing factors for neural tube defects, folic acid is one of the reversible or treatable cause of neural tube defects. Apart from these predisposers, there are multiple other predisposers which are required to be remembered. So apart from the zinc and the folate deficiency, hyperthermia, anti-epileptic drugs like valproate and carbamazepine, malnutrition, chemicals, maternal obesity or diabetes, trisomy 13, trisomy 15, and maternal exposure to alcohol or radiation, all those are implicated as predisposers for folic acid. But if you see, majority of them are treatable, that is hyperthermia, fever in the mother, using of anti-epileptic drugs, all these can be treatable and avoidable to some extent, but there are some inherent problems with the inherent problems like trisomy 13 or 15 which may not necessarily be taken care of until unless the genetics are addressed. So this is about the predisposer. So folic acid is now one of the, this folic acid has been found or implicated in the development of neural tube defects in up to 50% of the cases. That means folic acid is not the only culprit for development of neural tube defects. There are multiple other culprits also, and hence whenever you are giving folic acid preconceptionally for the prevention of neural tube defects, it is going to have for only 50% protection overall. Only 50% reduction in neural tube defects can be seen with folic acid. Rest 50% of the population who are going to produce an offspring will still have neural tube defects, because probably in those cases the other causes or predisposers of neural tube defects are still persistent. Now the next option which was being shown in the previous slide was the risk of recurrence. You have to know that neural tube defects, if you have one previously affected sibling, then the risk of neural tube defects is about 4% in the subsequent child. If there are 2 already affected children, there is a 10% risk of recurrence. And if there are 3 affected children, there is 25% risk of recurrence when it comes to folic acid deficiency and the risk of recurrence. When it comes to neural tube defects and risk of recurrence. Now the prevention is going to be only and only folate. So why the hell this folic acid is implicated in neural tube defects? So if you can remember, folic acid is one of the important vitamin which is required for 1-carbon metabolism, and 1-carbon metabolism is that aspect of biochemistry which is involved in the synthesis of DNA. Remember, folic acid plays a very important role in DNA synthesis. If there is deficiency of folic acid, the synthesis of DNA is going to get hampered, and if the synthesis of DNA is going to get hampered, that would result in folic acid deficiency. And if the synthesis of DNA is going to be hampered, it will result in neural tube defects, of course, because it is the 3rd and 4th week of intrauterine life where maximum organogenesis is happening, and including central nervous system develops in the 3rd and 4th week of intrauterine life. That is the reason why folic acid deficiency is to be taken with serious concerns. And remember, whenever you are supplementing folic acid, you need to supplement folic acid even before the mother is pregnant. That is, the initiation of folic acid should be preconceptional. Now, if a mother is if a female is planning pregnancy, preconceptionally, if you have to start the folic acid, then you are starting folic acid with an intent of primary prevention. So if you want to use folic acid for the purpose of primary prevention, the dose is 0.4 milligram per day. When it is used with secondary prevention intent, that is, if the mother is also already having a previously affected child and now you want to supplement folic acid, now the dose will be 4 milligram per day. That is 10 times the dose for primary prevention. So this is in brief regarding folic acid. Now let's get back to the question. Now you have to know that both meningocele, meningomyelocele and anencephaly, both are going to be neural tube defects. So if folic acid is deficient, then they should not cause one neural tube defect in preference over the other. Both are neural tube defects, so folic acid deficiency can cause both of these neural tube defects. So it is associated with reduction of not only reduction of if you supplement folic acid is associated not only with reduction of anencephaly, but also the risk of meningomyelocele will also come down, because anencephaly and meningomyelocele, both of them are neural tube defects. What is the dose of folic acid for secondary prevention? The dose of folic acid for primary prevention is 0.4 milligram, and the dose of folic acid for secondary prevention is 10 times the primary prevention dose. So it will become 4 milligram per day. So that rules out option B. So option B is also wrong. It's effective only during the stage of neuronal proliferation. Now this statement seems to be partially this statement seems to be correct, because this statement seems to be incorrect, because folic acid is not only involved in the state of neuronal proliferation, but also in the other states of development of central nervous system also. So it's partially correct, but not completely. But what about the option D, risk of recurrence? Now I had showed you in the previous slide, the risk of recurrence can be remembered by 4, 10, and 25% rule. So risk of recurrence is 4% if one sibling is previously affected. If risk of recurrence is 10% if 2 previous siblings are affected, and risk of recurrence is going to be 25% if 3 previous siblings are affected. So if you can remember this, the answer for this question would be D. That is the most accurate statement pertaining to this question. So by this we come to the answer, that answer is D. Just briefly going through the overview of neural tube defects, you should know that there are two types of neural tube defects. One in which the central nervous system is exposed to atmospheric air, that is, it is not covered by skin. That is called as open neural tube defects, that is uncovered with skin. And the other one is closed, where you have a defect in the central nervous system in the region of the neural tube, which is resulting in leak of CSF or what you call putting of CSF in a pouch or an cavity, but it is covered with skin, so it is not in direct contact with the external environment. So whenever it is an open neural tube defect, like as meningomyelocele or myeloschisis or INI-CET or encephalocele or anencephaly, you need to know that this is going to be a situation where the central nervous system is directly exposed to environment. And of course, when this happens, you are at risk of developing infection. So your baby is at risk of developing infection. If you expose it to the skin, it results in, if you expose it to the skin, it will result in infection. If you examine this open type of neural tube defects with your gloves, there is a risk of latex allergy. So these two things should be avoided. So you shouldn't keep the skin exposed to the atmospheric air. At the same time, you should not use your gloves to touch the uncovered skin. So here what you are supposed to do is, here you have to use a dressing material to cover the skin till the time the child gets operated, and that dressing would be only and only saline dressing. Using of povidone iodine or any other antiseptic substance is going to be counterproductive, as it can result in dense adhesions and complications resulting in problems with the spinal cord. So you should always do saline dressing. So one more important thing which you see with this neural tube defects when it is open is, since the CSF is in direct contact with the amniotic fluid when the baby is within the womb of the mother, then the contents of the CSF is also going to enter into the skin. So this will result in a situation where the alpha fetoprotein and acetylcholinesterase will go on increasing in their concentration. So maternal serum alpha fetoprotein and acetylcholinesterase in the amniotic fluid are going to be elevated, and they are going to be the indirect clues for presence of an open neural tube defects. For closed neural tube defects, you need to perform ultrasonography, and that is going to be providing you the definite diagnosis. Open neural tube defects, if you are able to find elevated maternal serum alpha fetoprotein levels and acetylcholinesterase, you start suspecting neural tube defects. So the open neural tube defects are anencephaly, encephalocele, INI-CET, myelomeningocele, and myeloschisis. When it comes to closed neural tube defects, it includes lipomyelomeningocele, lipomylosis, meningocele, myelocystocele, and there are some simple and complex type of neural tube defects which are of less importance, which is also written in the slide. So this is about neural tube defects. Now, once the baby is born, if there are some cutaneous markers, then at that point of time, you should start suspecting that these patients are having some occult neural tube defects or occult spinal dysraphism, and you should consider neuroimaging in the form of a CT or MRI in the newborn child. So cutaneous lesions which are suggestive of an occult spinal dysraphism is another MCQ which you can expect in your exams. So what are these cutaneous lesions? So these cutaneous lesions can be in the form of a subcutaneous mass or lipoma in the lower back, a hairy patch in the lower back, a dermal sinus, an atypical dimple. Dimple is nothing but a depression which is of 5 mm or more in depth and more than 25 mm from the anal verge, anal opening. So that will be called as atypical dimple. If you have any vascular lesion in the form of hemangioma or telangiectasia in and around the region of the spine, or you have a skin appendage or a polypoid lesion in the form of skin tags or tail-like appendages, or for that matter any scar-like lesions which can be seen in the region of the spinal cord in the midline, all these features are cutaneous markers for occult spinal dysraphism, and here you need to consider neuroimaging. So this is in brief regarding the neural tube defects. I would leave you guys with few spotters which can help you in identifying these and also in improve your audio-visual memories so that you can answer well in your exam. So can anybody tell me what is A, B and C? So just all these A, B and C are neural tube defects. The A and C options are the ones which are nothing but the cutaneous markers of spinal dysraphism which we have talked about. The first one is a lumbosacral lipoma. The second one is an intradural lipoma, which is of course not a cutaneous marker. The option B is not cutaneous marker. But what about option C? This is a patient with lipoma, but there is also a central dermal sinus. So this dermal sinus is going to be another indicator of cutaneous lesions. So clinical features and imaging findings are here consistent with occult spinal dysraphism, and here you need to intervene if the child is symptomatic. Now when you come to the other images, so here you can see the tuft of hair which is located in the region of the lower back. So this is called a spina bifida occulta. Then we have a child who is having a mass in the midline in the lower back. So here it is the meningocele. You can clearly see that this mass which is protruding from the midline in the back of the child is covered by a thick layer of skin. That means it is not exposed to the environment. So it is type of a closed neural tube defect. So it is meningocele. Then we have something called as a ruptured meningomyelocele, where the skin, where the interior of the mass is in direct contact with the atmosphere. So here, if you are trying to, if there was an MCQ which was asked in the previous days, now in the olden years, what is the dressing which you use to cover this sort of lesions? So you'll have to say that it is simple saline dressing that has to be used to cover this meningomyelocele. Otherwise, the skin and the cerebral spinal fluid will behave erratically to the povidone or any other antiseptic because of the allergic reaction. Then you have another mass which is arising in the back of the neck. So this is protrusion of the elements of the central nervous system of the brain into this cavity or this seal. This is called as occipital encephalocele. So this is spina bifida occulta. Whenever you have a tuft of hair, you start suspecting spina bifida occulta. This is meningocele, this is meningomyelocele, and this is occipital encephalocele. We'll go to the last slide, a few more spotters. Here you can see that the front portion of the baby's skull or the forebrain is practically absent. So this is a classical appearance of anencephaly, which is also a type of neural tube defect. Then we have another form of extreme flexion or retroflexion of the neck and trunk. Here, this sort of neural tube defect is called as INI-CET. And what is INI-CET? It is the dysraphism of the occipital region, which is accompanied by a retroflexion of neck and trunk. So this is in brief regarding neural tube defects. I think this was it for the day. I think moderator, we are done with 15 minutes. So can we stop here? I hope you have understood the neural tube defects in depth. We have practically covered almost all MCQs which have been asked previously and which is going to be having a high yield. in the current exams or the upcoming exams. So with this, we conclude the MCQ and the concept based discussion in pediatrics. So we'll move on to the next speaker. Thank you all.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.